Ms. JJ is a 21-year-old, previously healthy G2P1011 presenting to clinic with 2 days of increasing vaginal discharge and vulvovaginal itching, burning pain, and soreness. The patient reports the discharge is thick, white, and non-odorous. She does not report any lesions near her vulva or vagina. JJ notes that she has a new male partner. She has not been using condoms since she takes OCPs and is monogamous. She is worried that she may have developed an infection from this partner. She denies postcoital bleeding, but has dyspareunia and has been avoiding sexual activity for the past few days. JJ initially believed her symptoms were due to a yeast infection, and she has been treating it with an over-the-counter antifungal, miconazole, for the past day, which has not helped. She does report completing a course of amoxicillin for a sinus infection 1 week ago. She denies vaginal douching, taking baths, or soaking in hot tubs. JJ has no relevant medical or surgical history. She takes Yasin and multivitamin daily and has no drug allergies. For gynecologic history, JJ had menarche at age 14. Menses have been regular and occur every 30 days, lasting 5 to 6 days. Her last menstrual period was 2 weeks prior to presenting. JJ has not had a pap smear previously, but has been vaccinated against HPV. JJ is currently sexually active with 1 new male partner. She has 3 lifetime partners, all male. She denies any previously sexually transmitted infections, but she's never been tested for STIs. Her partners have not had sexually transmitted infections to her knowledge. She uses oral contraceptive pills for contraception and has used condoms in the past for prevention of sexually transmitted infections. JJ has no concerns regarding her sexual functioning. For obstetrical history, JJ is a G2P1011. She had an induced vaginal delivery of a 41-week, 9-pound, 3-ounce male in 2013 after an uncomplicated pregnancy. JJ had a spontaneous abortion at 8 weeks in 2014 that did not require D&C. For family history is negative for bleeding disorders as well as breast, uterine, and ovarian cancers. For social history, JJ lives with her partner and son. She feels safe in her current relationship and living situation. She does not smoke or use tobacco products. She reports social drinking with 2 drinks in a typical week, and she denies illicit drug use. Review of systems is notable for no fevers, chills, or sweats, no abdominal pain, nausea, or vomiting, no changes in urination, increased urinary frequency, incontinence, difficulty voiding, dysuria, or hematuria, no back pain, and no increase in thirst. On physical exam, BP was 110/76, pulse 60, respiratory rate 12, temperature 98.6, and BMI 22. JJ appeared to be well nourished and was sitting comfortably in no apparent distress. On abdominal exam, the abdomen was flat, soft, and non-tender to palpation in all quadrants. There was no CVA tenderness. On gynecologic exam, the external genitalia were without lesions. Vulva was beefy red with evidence of excoriations. Bartholin glands were non-tender to palpation. Speculum exam revealed a vaginal wall that was well rugated, erythematous, and with copious amounts of thick white discharge. The cervix was clearly visualized with a multiparous external os and no lesions, ulcerations, or discharge. Bimanual exam revealed a retroverted uterus that was smooth, mobile, and of appropriate size and shape. There was no cervical motion tenderness, adnexal masses, or tenderness. For studies, a wet mount was performed and revealed epithelial cells with no clue cells. KOH preparation demonstrated budding yeast cells and was whiff test negative. Vaginal pH was 4.3. In summary, JJ is a 21-year-old G2P1011 female presenting with 2 days of thick, white vaginal discharge and vulvovaginal itching, ultimately with history and exams suggestive of vulvovaginal candidiasis. Microscopic studies revealed budding yeast cells and normal pH with notable absence of clue cells and whiff test negative. The absence of clue cells effectively rules out bacterial vaginosis. A coexistent STI cannot be excluded, but based on the absence of cervical motion tenderness and adnexal tenderness, this seems less likely. The plan is to treat with a single dose of fluconazole 150 milligrams orally, as JJ has already noted unsatisfactory results with an incomplete trial of over-the-counter antifungal cream. Cervical gonorrhea and chlamydia screen, as well as rapid HIV tests, will be ordered as well. I will recommend a pap smear once JJ's infection has been cleared.